My name is David Nyberg. I'm from sunny Scottsdale, Arizona. I'm at the Fetal and Women's Center of Arizona, and today I'll be talking about the thorax. Welcome. I'm speaking about fetal thoracic abnormalities today. The topics I'd like to cover are briefly normal thorax and lung, and then conditions including pulmonary hypoplasia, briefly hydrothorax. I'm going to spend a lot of time with diaphragmatic hernia, and then talk about echogenic lung lesions in general, including cystic adenomatoid malformation of the lung and sequestration, and I'll also be discussing management. We get the opportunity to see the thorax and the lung in our normal fetal survey. Although we're not asked to take specific views of the lungs, certainly we get many views of the lungs during our examination, particularly when we look at the heart. And we look at the four-chamber view of the heart or other views of the heart, we see the lungs as symmetric echogenic structures encasing the heart and filling the lungs. So the lungs are easy to see during the course of a normal fetal survey. We can easily see the echo texture as well as the volume of the lungs and ascertain that they appear normal. We can also look at the vascularity, although that is not as helpful as simply looking at the image alone, but can be helpful in complications. We can see the airway in different ways. We can see the trachea if we look carefully, and certainly we can also see breathing through the mouth and the lips. This can be helpful, for example, in excluding unusual conditions like Coronal atresia. In that case, we wouldn't get this normal respiratory movement through the lungs and through the nasopharynx as we see here. We can also look at the lungs if there's any questions with magnetic resonance imaging, and certainly that has become much more prominent in the last decade. And I'm going to be referring to MRI in these conditions that we're talking about because it can be a very helpful complement to ultrasound. Again, MRI can easily see the lungs. They show up as brighter structures on most imaging, and again encasing the lungs, and again we can see the normal trachea and airways as well as the lungs themselves, and we can also see the vascularity. So a lot of information about the lungs and thorax with MRI. The major advantage is the superior contrast resolution of MRI, and so it can be quite helpful with lung abnormalities. Looking at normal development of the lungs, there's really three phases of lung development: the glandular, the canicular, and the alveolar phases. Just want to point out that critical lung development is early up to about 26 weeks. If there is significant hypoplasia up to that point, then it's likely that the hypoplasia will be irreversible. But if there is development of the lungs up to that point, even if there is hypoplasia after that, then usually it's not irreversible. The alveoli actually continue to develop throughout the pregnancy and even in postnatal life. We can assess the lungs and the thorax in a variety of ways. The easiest, besides simply the subjective evaluation of the lungs, is to measure the thoracic circumference. There's very good standards for normal values of the thoracic circumference, and at least in cases of overall lung volume, this is a good measure of the lungs. It doesn't work so well in certain conditions. For example, if there's marked cardiomegaly or other internal masses, for example, hydrothorax, that wouldn't tell us necessarily about the lungs per se. But in the absence of an intrathoracic mass, the thoracic circumference does give us a good impression and good values to be able to measure lung volumes. Again, we can also look at it in different ways, and there's using 3D volumes, either with ultrasound or MRI. We have good standards in looking at overall lung volumes with gestational age, and not surprisingly, and as expected, the lung volumes continue to grow throughout pregnancy. In terms of complications, I'd first like to briefly talk about pulmonary hypoplasia. Pulmonary hypoplasia is the end result of a variety of conditions, and when we talk about some of the later conditions, the complications are usually as a result of pulmonary hypoplasia. Pulmonary hypoplasia may occur from intrathoracic mass lesions such as diaphragmatic hernia or CCAMs, so-called CCAMs, which are cystic adenomatoid malformations of the lung, or other intrathoracic masses, also hydrothorax. All of these conditions can produce mass effects which compress the lungs and produce pulmonary hypoplasia. Another category, a major category, is external compression. This would be from oligohydramnios. If there is long-standing oligohydramnios, especially early in the pregnancy, this will result in pulmonary hypoplasia, which can be irreversible. Not only is it external compression, but also it doesn't allow the lungs to fill up with fluid and the normal respiratory movements that do occur during the pregnancy and allow the lungs to develop. Skeletal dysplasia is another category that can produce pulmonary hypoplasia, and virtually all of the lethal skeletal dysplasias do result in lethal pulmonary hypoplasia, and that is the reason that these conditions will result in fetal death. In those cases, it's a different setting, and that is the skeleton simply doesn't develop, the thoracic cage doesn't develop normally, and therefore it's constrictive and does not allow the lungs to develop, resulting in lethal skeletal dysplasia. I'm not going to talk about that particularly in this discussion, but that is typically quite obvious. Not only is the skeletal dysplasia quite obvious, but the subjective impression of pulmonary hypoplasia is usually quite obvious in those conditions. And then there's unusual causes that may result in primary pulmonary hypoplasia. How do we evaluate pulmonary hypoplasia? Well, the easiest is simply a subjective impression by looking at the lungs. Certainly if there's a mass, we want to appreciate the mass. If there's any intrathoracic mass or external compression. But then there's a variety of measurements we can make. Again, if there's no intrathoracic mass, the thoracic circumference is an easy measurement with good reference standards, and that would be the one I would recommend for looking at general pulmonary hypoplasia. But there's been a variety of other measurements that have been used, including lung length, lung diameter, and more recently lung volumes using 3D ultrasound and MRI. A variety of ratios have also been used, and some authorities have also looked at the pulmonary circulation with Doppler studies as a measure of pulmonary hypoplasia. This is simply one measure of pulmonary hypoplasia using a right lung diameter, and I just wanted to point out that at least in this study, the internal measure of the lung itself was superior to the thoracic circumference in being able to diagnose these the conditions of pulmonary hypoplasia. So thoracic circumference works very well when there's generalized pulmonary hypoplasia, but with not with all conditions. And we're going to get the most accurate measurements and determination of pulmonary hypoplasia by actually measuring the lung itself. And again, you can do that in a variety of ways. This is one of my attempts to measure lung volume in a patient with oligohydramnios and external pulmonary hypoplasia. And we can get a reasonable estimation of lung volumes using 3D ultrasound and calculating the volumes. In general, this will simply reinforce our own subjective impression of the lung volumes, but it is an objective measurement that we can compare. I'd like to move on to hydrothorax, but before I do, I just want to again mention that pulmonary hypoplasia is the end result of a variety of conditions we're going to be talking about today, and if there's adverse outcome, it's usually as the result of pulmonary hypoplasia. So a very important end product of all these thoracic conditions we're going to be talking about. Briefly, I want to mention hydrothorax. There's a variety of etiologies. It's not terribly common as an isolated finding. Usually it's associated with hydrops. Usually hydrops is evident in other areas, and so it's a fairly easy diagnosis. But in some cases it is isolated, and the etiology is uncertain. Certainly some of the etiologies we could think about would be infectious, and we'd want to look at things like parvovirus, would also want to look at conditions that may result in hydrops later, or sort of a prehydropic condition, and look, for example, at fetal anemia, and in that case you'd want to look at the middle cerebral arteries Dopplers to make sure there is not fetal anemia. Would want to look at chromosomes because it can be associated with Down syndrome and other aneuploidies, and occasionally Down syndrome will present with isolated hydrothorax. So the typical workup would include amniocentesis to evaluate the chromosomes, middle cerebral artery Doppler to exclude fetal anemia, obviously a good look at the fetus, and every other way to make sure there aren't other abnormalities, with particular emphasis on the heart to exclude heart abnormalities. And in the end result, we will be left with a certain percent of cases which are unexplained, and some of these may be the result of lymphatic disorders, so-called chylothorax, but in utero we don't have chyle, we actually have hydrothorax because the fetus has not eaten yet, so there isn't really any chyle in that fluid. Certain conditions then are idiopathic or associated with this so-called chylothorax. And I've seen several cases just in this last year which did fairly quickly develop to hydrops. So the other thing that we do is we'll certainly do a follow-up ultrasound fairly quickly within a couple of weeks to ensure that this does not develop into full-blown hydrops. But certainly my experiences last year, that is not an uncommon situation. The primary factor in evaluating the outcome is the presence of hydrops. If there's no hydrops, and no other abnormalities, and the chromosomes are normal, then the outcome is favorable. If there is hydrops, the outcome is very unfavorable, with almost no survivors. Certainly no survivors in this particular study. So that is another end result of a variety of lung lesions. If it results in hydrops, the outcome is quite poor. If there's no hydrops, the outcome is usually favorable, and that applies also to isolated hydrothorax. Treatment options for hydrothorax. Again, after a very extensive diagnosis, our options are to observe only, and I would recommend that certainly initially. Again, I would do a short-term follow-up, recommend a short-term follow-up in 2 or 3 weeks, or maybe even in 1 week, but a short-term follow-up. Thoracentesis can be performed, but there isn't any great reason to do that early. It's common to perform a thoracentesis shortly before delivery to help the lungs expand and help the neonatologist right at the point of delivery. But because the fluid will reaccumulate very quickly, thoracentesis is a short-term option and is not a cure, certainly. You can put in indwelling shunts, and here's an example of one where a shunt was placed, and at the time of delivery, another shunt was placed, but you can see actually where the shunt was placed in the side of the fetus. And this can be performed in utero with drainage of chronic isolated hydrothorax. It's not performed very frequently, but certainly it can be performed. Sometimes these fluid collections will continue to accumulate and continue to come back, and then we have to look for other treatments following delivery. And let me go back to that one just to mention one item, and that is the possibility of using sclerosing agents. This has also been attempted or performed in select cases prenatally, but more commonly it's postnatal. I'd like to go on and talk about and focus on diaphragmatic hernia. Diaphragmatic hernia is not an uncommon condition that we will see. Any major center will see a number of cases during the course of a year. The condition itself is quite easy to explain. It simply represents a failure of fusion of the diaphragm, usually the left-sided diaphragm, which produces a hole that separates the thorax from the abdomen, and now we no longer have an enclosed thoracic cavity. This allows the abdominal contents to come up from the abdomen and into the thorax and compress the lung and thoracic structures, producing a pulmonary hypoplasia. So the defect itself is relatively easy. It can be fixed surgically after birth, and that's not a problem. But the real problem is the development of pulmonary hypoplasia during pregnancy, which can be fatal. The diagnosis of diaphragmatic hernia is usually not difficult, but sometimes it can be. And what we look for on we've got several clues when we look at views of the abdominal circumference. First of all, what we fail to see is a normal fluid-filled stomach, and that is usually the first clue. Now, there are occasional cases where you will see a fluid-filled stomach and there still is a diaphragmatic hernia, but most cases do include the stomach as well, so that is a primary clue. The abdominal circumference may be small. As you see here, a so-called scaphoid abdomen, because the abdominal contents have herniated into the thoracic cavity. Other direct clues are looking at thorax itself, and of course, usually it's left-sided diaphragmatic hernia, so it's going to result in a mass effect on the left side. Typically, the stomach's involved, so we can see a fluid-filled stomach with compression of the heart and the mediastinum to the contralateral side, and again, usually that is towards the right side. And with large diaphragmatic hernias, the heart is compressed right the way to the right thoracic wall. After delivery, what we'll see is abdominal contents in the left chest, the stomach, and other abdominal contents, as we see in this radiograph here. So diaphragmatic hernia is relatively straightforward in terms of the actual condition and in most cases of diagnosis. But some cases can be difficult to diagnose. Fortunately, the cases that we might miss or are likely to miss tend to be associated with a much better outcome. So the ones that we're going to see are the ones associated with a worse outcome. The ones that we might miss or potentially could miss are associated typically with a good outcome. This is a view of a abdominal circumference in the third trimester, and unless you were observant, it would be easy to miss the fact that there isn't a fluid-filled stomach in this case. And certainly I've seen a number of diaphragmatic hernias that were missed by outside scans, for example, in conditions like unexplained polyhydramnios. Certainly you want to think about diaphragmatic hernia. Certainly if there's any kind of heart displacement or abnormal heart position, you want to consider diaphragmatic hernia. So you have to have a high index of suspicion. One way I like to look at it is in coronal or longitudinal views. In addition, of course, to axial views, not only are we looking at the thorax, but also I like to look at the diaphragm itself. And if you look here, you'll see the normal diaphragm over here, but as we come to the other side, in fact, we'll see, you can see the, and now we're on thoracic, now we're on a axial view, and you'll see that fluid-filled stomach, and we can see this in a variety of ways. Let me go back to this axial view. See the normal diaphragm here, but here we're going to lose it. Here's a fluid-filled stomach, and we'll notice that it goes right through a defect right here, through the diaphragmatic defect, and I think that we can ascertain the size of the diaphragmatic hernia actually very well in a direct way, rather than simply estimating it by looking at the degree of intrathoracic content. So think about looking at the diaphragm itself. I think there's a lot of information to be gained there. Diaphragmatic hernia can be missed or misdiagnosed. In this case, actually, was thought to represent, you could see a heart displacement, that was obvious, but there was interpreted as an echogenic lung mass. So initially misdiagnosed as a CCAM and not a diaphragmatic hernia. And it's very important to make this distinction. Diaphragmatic hernia, especially large ones like this, are not associated with a good prognosis, where CCAMs have a very good prognosis. So we want to look very carefully, again, look at the diaphragm itself on coronal or longitudinal views, but there's other clues here, and that includes a little bit of fluid. Now, you certainly can get CCAMs with cystic lesions, but if you just stop and watch, you'll usually be able to see peristalsis. And sometimes we're so busy scanning, we forget to just stop and watch. If you just stop and observe, you'll usually see a little bit of peristalsis in this bowel, which is herniated up into the thorax. So very important not to miss or misdiagnose. If there's any question, certainly we can get an MRI, and here is a longitudinal view of an MRI showing the intestines herniated up into the thorax. This is that same case I just showed a bit later, and confirming that in fact it represents a diaphragmatic hernia, not a CCAM. The three things really, what can we do with ultrasound when we are suspecting a diaphragmatic hernia? First of all, we want to detect it. Second of all, we want to look for associated anomalies. And the third thing we want to do is characterize it. And by characterizing it, we want to look at those factors that are associated with a worse prognosis. So first is detection. Second is looking at associated anomalies, making sure it's isolated. And that's very important with diaphragmatic hernia. Here's one case where we were able to easily tell that there was a large omphalocele. That wasn't a problem, but we actually missed the fact that there was an associated diaphragmatic hernia, and both of those conditions can produce pulmonary hypoplasia, and in this case it was a lethal pulmonary hypoplasia. This is part of the Pentalogy of Cantrell. Some of these omphaloceles can be smaller and could potentially be missed, so certainly look for that. But what we want to do is take a good look at the entire fetus and make sure there aren't any other associated abnormalities. Certainly the presence of associated abnormalities is a key factor in evaluating the prognosis, just as it is with any kind of birth defect that we may see before birth. In this study, there was 100% mortality when there were associated abnormalities, and associated abnormalities were present in a third of cases. In those diaphragmatic hernias which were isolated, the prognosis was much better, and we'll get to the factors that can be associated with a better prognosis. Looking at associated abnormalities, chromosome abnormalities were reported in between 5 and 15%. So it is important to confirm that chromosomes are normal as we go forward. And looking at the conditions that can be associated with anomalies, you can see a variety of syndromes here. And usually these will be associated with other conditions we can see by ultrasound. So again, one of the key points is to take a good look at the fetus and make sure there aren't any other abnormalities. Our third role, and especially at referral centers, is to characterize the defect itself and be able to separate those diaphragmatic hernias associated with a good prognosis from those associated with a poor prognosis. And a variety of factors have been looked at, and we'll get to that. But one of the factors that has prevailed as an important factor is the presence of liver in the thorax, whether the liver is up in the thorax or the liver remains down where it belongs in the abdominal cavity. This is a summary of some older literature, but certainly you can see big differences in survival rates or the need for ECMO, which is very vigorous respiratory support, and would like to avoid ECMO if at all possible, but a much higher chance of ECMO when the liver is up. Also, a much higher chance of requiring a surgical patch when the liver is up, and that's simply because the defect tends to be bigger than when the liver remains down in the thorax. So big differences whether the liver is up in the thorax or the liver is down in the abdominal cavity, and that's one of the things that we want to determine. And one of the ways we can do that, of course, we can look at the simply with 2D, but we can also look with color flow and duplex Doppler, and looking at the pulmonary and portal vessels can be very helpful, particularly as you follow the portal vessels up from the umbilical vein and they extend up into the thorax. Well, that's the clue that we have a portion of the liver up in the thoracic cavity. So looking at the vascularity can be very helpful for determining that. If there's any doubt, and certainly I think nowadays most people would also get an MRI, and I would encourage that to also determine whether there's liver up in the thorax or not. But I think the MRI has made us much better in terms of using ultrasound alone, and so there's very good agreement now, I think, at least in referral centers between ultrasound and MRI in determining whether the liver is up in the thorax or not. In this case, using the MRI, there's a portion of the liver up, as you can see in this coronal image, next to the fluid-filled stomach. One of the clues of looking at liver involvement in the thorax, actually, you can also use on transverse views, as in this case, and a key feature or a good clue that actually was suggested to me and probably to some of you in prior lectures by Ruth Goldstein was the position of the stomach. If there's no liver involved, then oftentimes the stomach is anterior, right up next to the anterior chest wall. But when there is liver involvement, the liver tends to be anterior and pushes the stomach posteriorly, as it is in this case. So here there's liver involvement pushing the stomach posteriorly, and that's a very helpful clue to looking at liver involvement with diaphragmatic hernia. And corresponding MRI, again confirming liver involvement. One of the things that's very important to do when we characterize thoracic problems, when we characterize diaphragmatic hernia, is evaluation of lung size, as I mentioned before. With diaphragmatic hernia, it can be more difficult because we've got this large amount of mass, sometimes quite big, and it can be quite hard to distinguish the intestines from the lung itself. So some of the ways of trying to look at it, it can be quite difficult. And a variety of ways have been attempted. Not surprisingly, the thoracic circumference itself doesn't work very well. The one method that has been suggested and seems to be standing the test of time, well, there's really two methods. One is looking at lung volumes, and that's a little harder with the ultrasound as we're looking at in this case. It can be done with ultrasound, but it's easier with MRI because of the superior contrast resolution as we see in this case. Certainly you can do 3D lung volumes using MRI. And there's very good correlation between 3D estimation of volume using 3D ultrasound with estimation of volume by MRI. So that is certainly one way to look at lung volumes, and probably the most accurate. But the method that has been adopted, I think, by virtually everybody now has been using this right lung to head circumference ratio, or so-called LHR, right lung to head circumference ratio. This turns out to be very helpful, and it correlates very well with lung volumes. So it simplifies the method. It's something that we can easily do as we're performing ultrasound. And this is how you do it. In a thoracic, in a transverse view of the that includes the heart, what we're looking for is the size of the contralateral lung. And we're looking, what we do is we measure it and the two diameters in millimeters, and multiply that and divide by the head circumference ratio, also in millimeters. That turns out it's very helpful and a very good correlate of lung volume. And now we're looking at the contralateral lung volume because the side of the defect, typically the left side, we really don't see the lung at all. It gets completely obliterated. And what we simply try to do is look at the contralateral lung volume, which is typically, again, the right side. And this is even though it seems like it's fairly simplistic and it's only on a single plane, it actually correlates very well, not only with lung volumes, but also, most importantly, with outcomes. And I'm going to refer to a couple studies, but they're all have similar conclusions, and that is the lower the lung to head circumference ratio, the poorer survival rate. And some people have shown a cutoff using 1, and others have used a lower cutoff of 0.6. But in this particular study, using certainly these lower values like 0.6 or below, the survival rate is very poor. And I think in most studies, survival rate is either 0 or close to 0 when the lung volumes are that small. In comparison, when we have a lung to head circumference ratio of 1.4 or greater, survival rate is very good. Something maybe approaching 90% in this particular study was 100%. But it's really very important to distinguish, because what we want to do is be able to counsel these patients appropriately, and it makes sense to give as specific information as possible to try to compare apples to apples and not apples to oranges. So we want to get as much information as we can. And fortunately, now we do have a lot of information about outcomes. I'm going to get to that in just a moment. This is important, and that is there's a good correlation again between lung to head circumference ratio and lung volumes using MRI. So we certainly can use MRI, but the lung to head circumference ratio with ultrasound alone, in fact, is very predictive. This is a valuable tool, again, to help separate those out with good prognosis from those with poor prognosis. And again, here's a study from the San Francisco group, which is the one that came up, which is a group that came up with the lung to head circumference ratio. And here they were able to identify excellent survival for those without liver involvement and with a lung to head circumference ratio of greater than, well, essentially 1.4. And in that particular series, there was 100% survival rate. So very important, at least in terms of counseling and be able to select those patients that have a good prognosis. I think this is an even better study that just came out last year, and I want to go over this a little bit in detail because it certainly provides us with the most detailed information we've had to date about neonatal outcomes using lung to head circumference ratio, and so very important. And here's the lung to head circumference ratios up above here, less than 1, intermediate range is between 1 and 1.4 and greater than 1.4. Now actually this study looked at observed to expected lung to head circumference ratios, not absolute numbers, but it corresponds roughly with these values. It turns out the lung to head circumference ratio does increase slightly with gestational age, but in the age range that we're looking at, these numbers actually work quite well, so you can use these absolute numbers as well. Just going through the various outcomes, the most important one, of course, is survival rate. And again, a major difference, less than 1, the survival rate is only 18% compared to almost 90% when the lung to head circumference ratio is greater than 1.4. Assisted days of ventilation, again, major differences, 38 days versus 9 days. Again, and using, looking at other outcomes like the need for a surgical patch repair of the hernia because the hernial defect itself is so large, 75% versus 9%. Again, huge differences simply by using this simple method of looking at lung to head circumference ratio. Other long-term outcomes that are important, gastroesophageal reflux is a major problem among survivors. And again, this correlates very well with the size of the defect and the need for ventilatory support during that period of time. So less than 1, 90% roughly have GE reflux, whereas when its ratio is greater than 1.4, only 10%. Again, big differences between ages to full feeding, full oral feeding, 51 days versus 19 days, or total days in the hospital, 73 days versus 31 days. So huge differences between those with smaller lung volumes as reflected by these smaller lung to head circumference ratios compared to those that have a smaller defect and therefore larger lungs and less pulmonary hypoplasia. Long-term prognosis is also important to look at. Survivors with diaphragmatic hernia can result in chronic lung disease, and that's much more common in those that required ECMO versus those that did not. We're also learning about or know about other long-term outcomes, including developmental delays and neurologic injury, cerebral palsy, and neurologic developmental delays in 22% versus 6% in those requiring ECMO and those that did not require ECMO. And looking at those that required a surgical patch, GE reflux, which can be quite debilitating, in 79% versus 11% for those that did not require a patch. And finally, looking at just looking at the need for ECMO, in another study, 100% of those with a lung to head circumference ratio of less than 1 versus 33% for those greater than 1.4. That's a different study than the one I just referred to. But again, coming up with the same conclusions, the prognosis is much worse for those with large diaphragmatic hernias, which are associated with small lung to head circumference ratios, and the prognosis is much, much better for those with smaller defects associated with larger lung to head circumference ratios. Also, having the liver in the thorax, intrathoracic liver, produces smaller lungs in general, and so that is also an independent risk factor for looking at lung volumes and outcomes. Particularly in this study I just referred to, the need for a patch, a surgical patch, was also associated with intrathoracic liver involvement. In terms of therapeutic options management, a variety of things have been tried, and we've had actually very good success in postnatal outcome improvements in respiratory therapy, and particularly, certainly there's a variety of options there. We can use ECMO if needed, which takes the total support away from the fetus and makes an external support for the lungs and the heart. But that should be a temporary measure only, and we try to avoid that whenever possible. As I've already pointed out, there are long-term outcomes, poor outcomes associated with the use of ECMO, which can include neurologic developmental delays as well. So we certainly try to avoid ECMO whenever possible. High-frequency oscillation is needed, and there's also a in more recent years, using low-pressure atraumatic ventilation, high-frequency low-pressure ventilation can be very helpful. What we try to do is minimize the trauma to the lungs, because there will be sequelae to that if there is trauma to the lungs. In terms of prenatal treatment, really our options are quite limited. We've had a large body of literature which has looked at various options in terms of prenatal surgical management, but all of those have fallen by the wayside, in large part because of the improvement we've made in the postnatal management. So there's been less need for more aggressive prenatal surgical options, and prenatal surgery really has gone by the wayside. The only thing that has continued is using a catheter, which I'll get to, a balloon occlusion catheter, which can be used in the worst cases to try to improve the outcome. But other kinds of prenatal surgery really have gone by the wayside, and the best thing we can do prenatally is to characterize those fetuses with diaphragmatic hernia, to be able to ascertain which have the good prognosis, which have the worst prognosis, and get that information to the parents and to the people who will be looking after the baby after birth, and that can be very helpful. In terms of the prenatal management that is still possible is a tracheal occlusion via detachable balloon. Again, there's been a variety of methods that have been proposed and have gone by the wayside, but there's still an ongoing trial using this method, and there has been some data that has suggested that it can be useful, particularly for those fetuses associated with the worst prognosis, that is with a small lung to head circumference ratio and with liver involvement as well. In this procedure, what happened, the idea is simply to occlude the trachea, and that allows the lungs to expand with fluid as it naturally would. For example, in cases of laryngeal or tracheal atresia, the lungs will fill up with fluid, and to try to counterbalance the development of pulmonary hypoplasia. So as it is performed today, this, if it is performed, it will be done typically around 26 to 29 weeks, and it will be done simply, it won't require a hysterotomy, but we can do it percutaneously with ultrasound guidance. The balloon is typically removed prior to delivery, so it's a temporary measure to simply expand the lungs. And again, there's some data to suggest this can be helpful in the worst prognostic groups. Here's some of the original data from now over 10 years ago, and looking at the worst prognosis groups, that is with a low lung to head circumference ratio and liver involvement, and they found improved survival rates using the tracheal occlusion method, particularly using the method I just described. So again, there's ongoing trials at several centers in the United States, and if you have a patient with a very poor prognosis, certainly I would encourage you to call them. CHOP Hospital, Children's Hospital of Pennsylvania is one, UC San Francisco is another, and you can call and see if your particular patient might fulfill that criteria. And again, that's only for the worst prognostic group. I'd like to go on and finish most of the rest of the talk talking about echogenic lung lesions. And I'm really grouping several different conditions when I talk about echogenic lung lesions, acknowledging the fact that it can be quite difficult to distinguish some of these conditions. The most common one we would consider here or think about would be cystic adenomatoid malformation of the lung. I'm going to refer to it as CAM just because it's a lot easier to say. Sequestration, which is similar but different, and there's actually overlap with CAM both by imaging and pathologically. And there's also other conditions that can produce echogenic lung lesions, including airway obstruction, really any cause of obstruction. And here's one case, it's an older case from the literature, but it's interesting that there's a very large echogenic mass filling the left side of the thorax here, producing cardiac displacement. It could easily be diagnosed as a CAM, but in fact the underlying condition in this case was tracheal obstruction or stenosis really by a bronchogenic cyst. So it points out the fact that any cause of obstruction can produce what happens is the lungs fill up with fluid, they become expanded. We see multiple interfaces because of the fluid filling the alveoli, and they show up, these multiple interfaces show up as echogenic lesions with mass effect. Kind of a classic one condition is this, where we've got markedly expanded lungs on both sides, so the heart's actually compressed in the middle, and we see that really the thorax seems to be completely filled with the lung tissue. There isn't any other mass effect per se, and it's very symmetric. This is a very diagnostic condition. When we see it, it's one of two conditions. It's either tracheal atresia or laryngeal atresia, or combined you can talk about it as high airway obstruction. And that's a very typical condition. Unless it's quite high at the laryngeal level, they're associated with a poor prognosis. If they're at the level of the larynx, it's possible to actually catch those at the time of delivery, do a tracheostomy and avoid the obstruction, but that's only been performed in a handful of cases. Here's another echogenic lung lesion filling the one side of the thorax here, in this case the left side, with contralateral displacement of the heart. This is an older case but typical of a CAM. Here's one that's echogenic with cystic areas within it, and the most common in my experience is simply echogenic, or with echogenic with one or two or small cysts, but sometimes they can be mostly cystic and so-called macrocystic lesions, so they vary. The typical echogenic ones actually have a very good prognosis. We can also see these with MRI. These seem to correspond to lobar involvement, and we can characterize where they are, how much of the lung they involved, and confirm that in fact it is a CAM and not a diaphragmatic hernia. Notice in this case, looking at the MRI, we can clearly see the diaphragm and separation from the stomach below the diaphragm. So MRI again can be very helpful. One thing we do when we look at lung lesions is also look at the vascularity in an attempt to distinguish CAMs from sequestrations. Sequestrations typically have a arterial supply from the aorta, a systemic arterial supply, and we can oftentimes see that by ultrasound. It can also be seen at the time of surgery. Another case of sequestration with a arterial systemic supply. But in fact, there's overlap between CAM and sequestration, both by imaging and pathologically, so it's not so important to absolutely make this distinction. Here's another case of a very good example of arterial supply with a sequestration. And again, we can look with MRI and we can see systemic vessels, sometimes with MRI itself, but usually that's performed better with ultrasound and Doppler imaging. Here's one that had combined pathologic features of both the CCAM and a sequestration. Again, a very typical looking lesion with a echogenic lung mass, in this case just a small cystic area with marked displacement of the heart and the mediastinum. By the way, in the older literature, if we looked at these kinds of lesions, we would have said, gee, this looks really bad. There's marked displacement of the heart. This has got to be associated with a poor prognosis. And in fact, the older literature suggested it was. But the natural history is such that these actually have a very good prognosis, that these lesions will look like they disappear, they look like they resolve, and the heart and the mediastinum will return to their normal position in the vast majority of cases, particularly these echogenic masses. So we give a uniformly favorable prognosis when we see these. Here's here's one example where we've got an echogenic lung mass at 22 weeks at birth that looked completely normal. And I guess the question is, was that a CCAM or was it a transient obstruction, a bronchial obstruction? Unless that fetus, unless that neonate has surgery, we won't really, we may not know. Here's another one with a large lesion. It can look quite impressive, but this is a CCAM, and in fact on follow-up it actually looked very good. It became harder and harder to see. Here you can see on a follow-up the heart returned almost to normal position, and the lesion itself was now becoming very difficult to distinguish from the adjacent lung. And that's a typical scenario. So the CCAMs and these echogenic lung lesions are much easier to see in the second trimester than they are in the third trimester. And the typical natural outcome is, in fact, that they will resolve and may become impossible to see. Here's another one, a large echogenic lesion, mass, and on follow-up became virtually impossible to see. So if we had seen this patient only in the third trimester, we would not have known that there was a lung lesion present. Once again, you can characterize these by measurements and lung volumes, but that's not as important here because regardless of their size, they're associated with a good prognosis, at least if they don't have hydrops. Now, when they look like they resolve, do they actually resolve? We did a study when I was in Seattle looking at 10 patients with what looked like CCAMs. 4 looked like they resolved completely after 32 weeks. 3 looked like they almost resolved, but there was just subtle alterations in echo texture. In fact, we would have easily missed them if we had only scanned them in the third trimester. And they can look normal or near normal on postnatal x-rays, but all of them had an abnormal CT scan, as we see in this case. So there is a mass that does persist. It's just that it looks like it resolves both by ultrasound, and it can look relatively normal on a chest radiograph. So our protocol is to get a CT scan after delivery. Now the real question is what to do with those lesions. I'll get to that in a moment. But one question is, why do they look like they resolve? And there could be different reasons. The fetus certainly grows while the mass size maybe is quite stable. Also, maybe there is relief of the obstruction, which could occur, of the trachea or bronchi. So there may be different reasons why the mass effect actually looks like it resolves. But I think what happens is probably the mass itself remains stable and the lungs are able to develop and grow around it. So it becomes less prominent and less echogenic. The prognosis for CCAMs and sequestrations, these echogenic lesions, is again excellent when there's not hydrops, and that's really the key. If there's hydrops, the prognosis is poor in this series, but if there's no hydrops, then 100% survival rate. So again, excellent prognosis without hydrops. The other thing about CCAMs and sequestrations, these echogenic lesions, is they're almost always isolated. They almost never have associated abnormalities. So overall, even though they can look quite worrisome early on in the second trimester, they really have an excellent prognosis, and the key is, of course, to distinguish them from other conditions like diaphragmatic hernia. A couple conclusions. These echogenic lesions are certainly more common than generally recognized, and in fact, if we don't look in the second trimester, we may miss them entirely. And since the patient may be asymptomatic at birth, if the patient wasn't scanned at the right time, they would go completely unrecognized. Even though when they look like they're resolved by ultrasound and they're asymptomatic, it does not mean that the lesion is gone, and it may persist. Now, typically, the natural history of these is is actually hard to know, but they can develop recurrent infections later in infancy, and there's also a small chance of development of, at least authorities think there's a small chance of development of a rare kind of tumor, blastoma, later in life. So these are the reasons why, if resection is performed in an asymptomatic patient, why they would recommend surgery. But certainly this is a area of controversy and deserves some further study. What is the optimal management for these lesions, particularly in patients who are asymptomatic? In our own experience in San Francisco, when we tried observing alone, the surgeons started to see so many of those, they started observing alone. But oftentimes they did develop respiratory infections later in the first year of life, and so they changed their approach to perform prophylactic surgery. Another option that's been suggested and has performed has been arterial embolization of these lesions, which would avoid the need for surgery. And in this study, 16 patients went arterial embolization, and it looked very successful in all patients except one and two other patients. It was partially successful. The very last condition I want to mention before I conclude here is something that, here I'm looking at the abdomen, but it is related to the thorax, and that is these echogenic lesions, masses, which are in the left upper quadrant behind the stomach, and they're really very diagnostic when you see them. Here's an echogenic mass, and this represents a extralobar intra-abdominal pulmonary sequestration. Very typical. Now, some people can get worried and think, what about a neuroblastoma? But I've not found it difficult to distinguish that between a neuroblastoma. Sequestrations are always on the left side, these intra-abdominal sequestrations. They're homogeneously echogenic. They're seen in the second trimester or beyond, and they're relatively common. Neuroblastomas may be seen both on the right and left side. They're usually of mixed echogenicity. They're not homogeneous. Because they're tumors, they're only seen in the third trimester. They're not seen in the second trimester, and they're relatively rare. So just to keep an eye out for these conditions, because when you see them, it's quite diagnostic. Well, I'd like to conclude here. Thank you for your patience, and conclude by saying that prenatal imaging, which includes both ultrasound and MRI, has broadened our knowledge of congenital lung abnormalities and also their natural history. I believe that's improved our ability to select patients and be able to counsel patients, and that's been very helpful because there's been tremendous improvement in postnatal therapy for conditions, especially things like diaphragmatic hernia. The prognosis remains poor for those diaphragmatic hernias with large defects and small lung volumes, and we really don't have a lot to offer except for this experimental procedure which I described in those with a worse prognosis. Prenatal diagnosis is essential for, first of all, determining the correct diagnosis and then help guiding counseling and management. Thank you very much for your attention.